And I hope everybody had a good weekend and a safe weekend, and a nice clear day with clouds and no smoke, so we don't have that smoked ham or bacon feeling. And all the animals are following us around. So we'll go ahead and go into open session. And I'll call the meeting to order at 4:30. And we will, first of all, we all should have had our agenda. Ms. Watt was good enough to send the agenda out on our email, so I'll take a approval or disapproval of the agenda today. In front of us, we've got a fairly good meeting today. Well, I'll take.
So move to approve the agenda.
Do I have a second?
I'll second that.
All in favor?
Aye.
Next one, consent agenda. Was also in our packet that Ms. Watt provided to us, so I'll take approve or disapprove. Motion to approve or disapprove the consent agenda.
So move.
Have a second?
I second that.
All in favor?
Aye.
Approval of the minutes, you should have the minutes in front of you from the August meeting. You want to take just a minute and look them over one more time.
So move to approve the minutes of August.
You have a second?
Meeting.
To approve the minutes? I'll second.
Waiting for a second? I'll second.
Yeah, okay. A point of discussion, if you look in the first page of the minutes, we need to add a Y on February 18th.
It's all my single copy version.
Oh, okay, so that's been done.
Yep.
Thank you very much.
You're welcome.
We will then adjourn session and go into close at
We're all in favor?
we're all in favor.
We're all in favor. Yeah.
Yes.
Okay.
safe weekend and looked like we had a good day for no smoke.
Yes.
So we're going into open session. And we only covered 2 items in the open session with our time ran out. Chief of Staff report, and that was information only, quality review. We need to take a motion to approve or disapprove the quality of care, peer review, and credentials. So move. Have a second?
Second.
All in favor?
Aye.
Thank you. Next, we heard the quality division.
Do you need a separate vote on the annual patient safety and risk report?
Yes. He's good.
And the quality division was the information only. And then we had a report on the patient safety and risk report on committees. And I'll entertain a motion to approve or disapprove the risk report that was presented.
So move to approve.
Have a second?
Second.
All in favor?
Aye.
Thank you. The other C, D, E, and F we will do after open session is finished. So we'll move on to public comment. Any public comment? Anybody else in the public? Bonnie, do you have anything? Mr. Lunella from email or anything?
No.
Other comment?
He needs that.
I have one comment. Last month, we had a comment read, an email I got from Dr. Jindal, and we have another public comment from Dr. Jindal today. So I'd like to read this into the record. And when it comes time, I'd like to have this added to next month's discussion at the time. So it says here, dear Dr. Sorrell, this is a continuum of my last letter to the board pertaining to hastily carried out summary action without a due process at July 27th meeting. I hereby respectively submit and reiterate that board A, now we have several items, obtain sworn statement from witnesses and accused if not already done, investigate accusations of misconduct on part of 2 members of previous board as alleged by Director Pandya if not already done. C, make all these documents available for public scrutiny and comments since they pertain to public officials and clearly not confidential as relating to personnel or HR issues. As the apex body of public institution, it is board's right and responsibility to make sure that its actions conform to judicial principle of fair play and are transparent so as not to be overturned on legal challenges which can only bring ignominy to itself and its legal advisor, Cindy Rakesh Jindal. So we'll read that in the records, and when it's time, we'll have that for next month's agenda and his prior letter. So if there's no more public, we'll go on to the hospital report by Ms. Hefner.
Sure, yes, thank you. I have two recommendations I'd like to present to the board. And most of my update will be in the COVID update, since the last 30 days have been all about COVID. So I'll say that. So for this month, we actually have 2 leaders that have received some distinguished awards. Brandy Irwin is our Director of Acute Care and Nursing Excellence, and she received Nurse of the Year Award for Excellence in Nursing Research by the Nursing Leadership Coalition of the Central San Joaquin Valley. And she did this in regards to her co-authorship and in regards to a research practice that they implemented this last year on patient experience scores and the art of leadership rounding. So her recognition, I just wanted to present publicly because her and the next leader I'm going to honor actually made the trip to Fresno to be the recipients of this award. There was 4 categories and Sierra View, right, 4 categories, and Sierra View leaders took away 2 of the 4 categories, which was quite remarkable, which I don't know 2 of our nursing leaders ever to receive these awards in the history that I'm aware of. The second one is our distinguished leader, Jeffrey Hudson. He received the Nurse of the Year Award for executive leadership and by the same organization, Nursing Leadership Coalition. And he has also, in addition, been inducted into the Hall of Fame for the Central San Joaquin Valley. So congratulations. So a lot of work. He was actually recognized by his peers for his leadership, not only in our organization, going to the bedside, fostering nursing leadership development, but also for the work that he's doing for ACNL. And he chaired for a couple years and passed the chairmanship over to a colleague of his in Bakersfield, I understand, in Kern. So we're very honored to have 2 recipients of these 2 distinguished awards, Nurse Leader of the Year. Congratulations. And he has a beautiful plaque that he received as well. So, and I'll get to turn it over, if it's okay with you, to Janice, who's going to give you a foundation report.
Sure, very good.
You got a jacket too, Jeff, or a jacket with a Hall of Fame?
No jacket.
Get the green jacket.
Didn't come.
Oh, I thought she did. No. Oh, okay.
I'm gonna wing it.
To get
You're
the-
going to meet us like, okay.
First of all, I'd like to thank you to allow us to come in tonight and give you a quick update on the foundation. We kind of recap what we've done over the last couple of years because of COVID. First, there's 16 foundation board members. These are volunteers in the community. We do several things. We have a CPA. We're very lucky to have a CPA on our foundation board. She prepares our taxes. She works with our third-party audit company. And she does our bookkeeping services. That's Marty Lalani here in town. She has just finished recently the audit. And it was nice to see that there was no findings in the audit. There was no mention of anything that needed to be corrected. And it was a satisfactory audit. So we're very happy about that. That was for 2019, 2020. Last quarter, the first quarter of this year, we presented to the board for $150,000. That was a combination of some of the things that had happened in 19 and in 20, which there wasn't full fundraising during those 2 years. Both of the 150,000 went to the MRI machine. We fundraised for that machine, I believe, 3 years in a row. And we've given a little more than $300,000 for the new MRI machine. In April of this year, we did the golf tournament. It was one of our most successful golf tournaments that we've done, but it was also a combination. People had given money for sponsorships in 19 and of course in 20, and of course that one was postponed. So we contacted those people and they said, no, just keep the money. So a combination of that and then the actual golf tournament, we grossed $54,980. We are currently fundraising for another golf tournament for the GME program here at Sierra View. And we're going to be holding our Driving for Docs Fall Golf Tournament on October 15th. For those of you who don't golf, which a lot of our foundation members do not golf, we are taking sponsorships for as little as $250 for a T sponsor. up to $3,000 for a golf cart sponsor. When we talk about the foundation, they give a lot of time, they give a lot of talent, but they also do monetary. There's a requirement to be on the foundation board that they have a monetary commitment to be on the board. So I thought I would share with you tonight. Sure. Share with you what they receive if they should miss a meeting, what they receive in the mail. So I made an example of the invoices that they receive from the foundation. So their invoices to be part of our foundation for any event that we give is $250. We would very much enjoy if this board would like to give toward our golf tournament. But I also wanted you to realize how very important it is that the foundation have this commitment to the hospital. Any questions or comments that you would like to ask now about the presentation? No? Okay, thank you for your time. We appreciate it.
We really appreciate you.
Very good. We thank all the work the foundation's doing.
Yes.
We couldn't get along without it, so thank you very much.
It is great that they're meeting back in person again and
Oh, yeah.
yeah. we're-
This Zoom meeting's strange. I'll entertain a motion to approve or disapprove the foundation's annual report.
So move.
Have a second?
I second it.
All in favor?
Aye.
Aye. Thank you. Mr. Dixon.
Thank you. Thank you, Janice. Thank you, Kim.
I think we have some good reporting to do. Maybe.
Hope so.
Looks good.
All right, so we usually do start off with statistics for the month of August. Acute days for the month, only about 27% greater than we had budgeted. Our length of stay was 20% higher. We did not, when we budgeted, anticipate the resurgence of COVID. Impacted length of stay. Long-term care, a little better than budget, and probably as important as anything, outpatient visits being up compared to budget. And then year to date, we're 16.5% above budget on acute days. Our outpatient visits are up 4%. And then compared to a year ago, the days inpatient acute 15% greater. Our long-term care days are down about 6%, and outpatient visits are up 10%. So that's probably the biggest change, is outpatient coming back. The August revenues, total patient revenue for the month was 9% greater than budgeted. Deductions were up 7%, so net patient revenue was up 15%. Other operating revenue off 8%, we were up in total operating revenue 1.6 million or 14%. Our expenses for the month, salaries, wages, and benefits, we were actually below budget 2%. You can see supplies were up, purchase services, again, those are impacted by what's going on with COVID. The total operating expenses for the month, 300,000 or 3% or so above budget. We had a gain from operations of 623,000, 4.6% margin for the month. Positive variance of 1.3 compared to budget. And then non-operating items. Total non-operating revenue, 341, better than we had budgeted. So our increase in net position before considering the investment, the fair value measurement, 964,000. We had a decrease in the fair value of investments, which is going along with interest rates, moved up a little bit for the month, which is going to write down value of the investment, so we have an increase in that position of 601,952. And then looking at year-to-date, total patient revenue, we're up 4%, net patient revenue is up 7%. A little behind on other operating revenue, but overall, we're up about $1.25 million in operating revenue. Year-to-date expenses, salaries, wages, and benefits overall, we're below budget there. Under 349,000 overall on our expenses, so we have a $229,000, $230,000 gain. Non-operating items, 593,831, a little better than budget, so we have an increase in that position before fair value of investments of 823, decrease in the fair value of investments, so we have an increase in our net position through the first 2 months of 522. And then compared to a year ago, you can see the gain from operations at 229 versus a loss of 622. So we're in better shape than we were a year ago. And then just going through, so on our investments, the interest rate impact, if you look back over fiscal 20 last year and then this year, you can see the decline. The year-over-year change for this year is 210,000, and just comparing to a couple of years ago, it's dropped 359,000. So that's just the interest rate impact on it. Staffing cost right now running 55.9%. So pretty good shape. We're below the budget of 59.8. So that would have a under budget variance of 531,000. Compared to a year ago, the variance is at 296. That's in our favor for being under. So, provider pro fees through the first 2 months, 125,000 below budget. We're 42,000 more than we were last year at this time. And then
Are we paying for a lot of locums now? Or normal or under or?
Still not the same.
Not the same. Excuse me.
Right, and then days cash on hand, and we're still in pretty good shape. Cash to debt percentage, operating margin now at 0.9. That's better than where we've been in the last year. The EBITDA margin of 9.2. Debt to capitalization is good, and our debt service coverage is in good shape at this point. And then finally, a little update: provider relief funds. Phase 4 applications are now open until October 26th. So we'll put in an application for that. If it goes like the others, we might get about 2 or 2.5 million out of it. We'll see. We did not budget for anything like that, so whatever we pick up is a positive. And then reporting for the period ended June 30 of 20 is due by the end of this month, a couple of days. They did put in a 60-day grace period, but we just assume not have to deal with that. So that's one of the things we're working on right now. Any questions about August?
Good job.
Good.
Good job.
Keep up the good work.
Did you write down how you did that and have a record? So we can use it again?
So Doug, on the provider relief funds last year, we got all waived, right? And we have enough deficits for.
Oh, yeah, we received between 5 and 6 million. We can demonstrate lost revenue far greater than that, let alone expenses.
So we don't have to pay it back. Okay.
I would never say never because everything is blessed and done, but
Until it's done, right?
yeah.
Okay, I'll entertain a motion to approve or disapprove the financials.
Make a motion.
Second,
Second.
all in favor? Aye. Good job. Very good. Next, we'll hear from Mr. Tracy Reed, and we're going to go over our 3 new procedures that we have.
Okay. So last meeting, we presented each of the 3 items. So we'll just go through them one by one. Starting with the code of ethics and conduct for elected and appointed officials, the policies and procedures. Any board member have any questions or issues pertaining to the ethics policy.
Make a motion, I'll entertain a motion that we either approve or disapprove code of ethics and conduct for elected and appointed officials.
So moved.
Do I have a second?
A second.
All in favor? Aye. Aye. Thank you. Next, we'll move on to unauthorized disclosure of privileged information.
And similarly, this was presented at the last meeting. A month was given for the board members to look it over. Does any board members have any questions or are there any issues?
I have one question. On the title is unauthorized disclosure of privilege. And then under the purpose, it says a person may not disclose confidential information. Should that say privilege? Since it talks about privileged information, or should it say confidential / privilege?
So the privileged information I would view as maybe broader than necessarily the confidential information. The confidential quote, I think, directly from the statute. Whereas the overall policy used a different name. So I'm not sure that the difference in nomenclature there
Okay.
would have any material bearing on it.
If someone's gonna say, well, we say privilege, then it's confidential down here.
Basically, we are talking about closed session information, is that right?
Correct. Well,
Whatever is discussed in the open session is for public consumption, right?
correct, but it's not just closed session because we're including what to do when employees or other officials disclose confidential information.
But that would be in the closed session anyway, right?
Well, yeah, and I mean, it's sort of an overlap of.
So the two can be interchangeable,
Right.
privilege and confidential.
Yeah, generally speaking.
Okay, that's fine. That's all I had. Does anybody else have any questions on
Yeah.
the unauthorized disclosure of privileged information?
We need to sign this and give it the first word.
Okay, no more questions. I'll take a motion to either approve or disapprove the procedure on authorized disclosure of privileged information. We have a motion.
Second.
Motion approved. We have a second.
Second.
Second. All in favor?
Aye.
Aye. Aye. Motion carried. Next and last is the board procedure for hearing to censure a board member.
Okay, just as with the other two, these was presented at the last meeting. Do any board members have any questions or wish to give any input?
I have one. Under purpose, the second paragraph, at the end of the second sentence, the first paragraph, if a member of the board is found guilty or liable by any court of law enforcement agency, administrative hearing officer, or public agency investigation of violating a law or regulation as that term is defined, should we put board in there? Or are we a public agency?
Well, you are a public agency, and I think the censor policy is how the board would find somebody guilty.
So we don't need board in there.
I think it would be redundant.
Well, that's okay, that board. And on the third paragraph, we have a list of different things. Should we have included in that board bylaws or the ethics policy that we just approved?
So we have the final line, censor may be initiated for breach of any of the board's ethics policy or violation of any law or regulation of both. So the ethics,
Should that be covered, board bylaws or the ethics policy we just
So that you're saying that it specifies the exact name that we used on the other document?
Mhm,
That it'd be the Code of Ethics and Conduct?
mhm.
Yes, yeah, that probably would be a good change.
So I think we need to add that to that. Anybody else have any questions or thoughts or anything? Dr. Spandy?
The first paragraph, it does talk about ethics. Well, I don't know.
Yeah, ethics covers this whole thing.
Yeah.
So the procedure for
This is the censorship.
censorship is in the ethics.
Yeah.
So I think that's important. I'll entertain a motion to accept or
I make a
approve or
motion.
disapprove the procedure with the change.
I make a motion to approve as.
Do I have a second?
Second.
All in favor? Aye. Aye. Thank you very much, Mr. Straith.
Someplace.
Next, item F is reconsideration of censure of Director Lorraine Candia. At this time, so I'll start with Dr. Bill, what he thinks.
If I may,
Sure.
I'd like to introduce my attorney,
Yeah,
Mr.
we met him last time.
Okay, and he will be representing you.
Okay, so now I'll let Dr., you can speak. I'll have Dr. Bill first.
I think whatever decision we have already made, I think we should abide by.
I concur because we did not have these in place to begin with. We felt there was sufficient evidence at that day that we were satisfied with the decision. There's nothing to say.
Mr. Bernard.
Just question again?
Oh, excuse me. It's just reconsideration of censure of Director Lorraine Candia. Now we have these things in order and we've already gone through one censor, but is it since now we have him in writing and everything, do we want to reconsider it or continue on with the censor following these guidelines?
Yeah, I think I'm fine with going what we already have decided on.
Okay, Dr. Pandya.
Could I ask the board whether or not I might be permitted to speak on this issue?
Do what?
What to speak on?
I'm asking if the board would allow me to speak on behalf of
Sure.
Dr. Pandya. Yeah. Part of the concern, of course, and I raised this in the letter to Mr. Crace that I sent about 5 weeks ago. And I do thank you for allowing us to come back again and present this as a motion for reconsideration. The concern is that the policies that were just adopted really are salutary from the standpoint that any member of the board, and that would be all 5 of you, of course, now have the safeguards that are built into those guidelines that have been adopted. And if they are good safeguards, which in my opinion they are, I mean, I think they coincide with standard due process safeguards that we have in legal proceedings. I mean, I'm a litigation attorney, and what we do as trial attorneys, it's like second nature to us that if there's a complaint, then the person that's charged with the complaint is given a fair opportunity to meet those charges. And the great thing about the guidelines that were just adopted, it basically establishes that fundamental principle that if there is one of you who is charged with a violation of law or violation of a regulation, that it now is to be set forth in writing, and you're given an opportunity to read it and a fair amount of time to address it and present your opposition in writing. And one of the things that's, of course, very beneficial about the policy that was just adopted is that you or whoever it is that's charging one of the members of the board with an offense that might warrant public censure has to identify the violation of law or regulation that is the basis for the public censure. And not to mention, it is also very beneficial that if there is a problem that's identified in the written complaint that's supplied to somebody and given a chance to address it, that they are permitted to correct the problem before they are subject to public censure. None of these safeguards were afforded to Dr. Pandya. Now, the comments made by members of the board is to the effect that these policies were not in effect at the time of the decision that was made by the board for Dr. Pandya, and therefore we don't need to comply. I agree, you don't need to comply, but we're asking that you do comply because the end result of the process is frankly unfair because Dr. Pandya was not given an opportunity to even know what the charges were, to have a fair opportunity to refute them and to address them in a proceeding that is equivalent to what happens in a court of law. In other words, the party that is the accusing party gives the party that's responding an opportunity to respond, and then the decision is made, okay? So, I mean, what happened just a moment ago before I spoke was that, Mr. Solos, you invited other members of the board and everybody to make a decision before I even spoke, okay? So it's a repetition of the fundamental problem of lack of due process that Dr. Pandya had, okay? So we're not in a position to impose on the board any kind of rule or regulation to say you must reconsider. We're here to ask for reconsideration. But by the time I present my.
But we're not voting now. We haven't voted. We just.
Okay, all right.
Everybody.
Sure. I mean, to the extent I'm permitted, I would ask the board to take a vote on the reconsideration. And it's not a, something where I can, stomp my foot and say, you must do this. I'm asking on behalf of my client, okay? And I think looking at it objectively, there's a problem here, okay? And I would emphasize for all of you that, what's good for the goose is good for the gander. And you guys are going to be serving on this board going forward. And the safeguards that you just adopted are great. They protect all of you. But I think as a consideration of your colleague on the board, I do think it is fair, just, and the right thing to do. To vote for reconsideration and allow them to have those same safeguards. That's our presentation. That's what we're asking for.
But I will say Dr. Pandya had the opportunity to face his accuser and face a witness and heard from the witness, and he explained himself. And true, we haven't put these in place yet, but he did have that. So what I plan on doing is, under these rules, we're going, well, depending on the vote, how it comes out, that if they do vote to recensure, we will do these rules and he will have a letter with the censor information on it. And we'll have time, 10 days to rebuttal on that. And we will, at the next board meeting, have a hearing to do that.
Right, that's all we're asking for.
So
Yeah.
that's
all we're asking for. Thank you.
So that will be done.
I mean, you have to vote on that, right? Is that?
We're going to vote. If there's, Dr. Penny want to say anything, we're in discussion now, so.
No, I think, enough is said. Basically, there was either a misunderstanding or misconstrued. The comments that I made were for the protection of the district. And the indications were that, and whatever testimony that was presented was not accurate. And so I'm not sure. Whatever was discussed it was in my official capacity as the vice chairman. After you left, I was still conducting the meeting, and I asked a question, why such and such was done. And, then that is where I was wearing the board hat, for trying to see that there is some danger to the district. And that's all that was to it. It was like a 30-40 second conversation. And I'm not sure that, I think the mountain is right out of a molehill.
That's understandable. We will have witnesses. So there was a witness to your comment. So we'll have a witness next time. In fact, that same witness, what he testified to in June when we talked about this. And so if you want to have a witness to testify what he heard or she heard, we can do that. So we'll have this at our next meeting. So you'll have a full opportunity to try to correct what you did. And it's hard to correct something verbally that is unprofessional and fairly toxic in nature. Once it's said, it's hard to take it back. So, but anyway, let's go ahead and we'll have a vote. So I'll entertain a motion to either approve or disapprove, following on with Dr. Pandya's censor. So we have a motion to approve or disapprove following on, reconsidering.
I didn't understand the motion. So keep the motion, the motion to keep the censor on.
No, it would be, the censor's there. It'd be a motion to reconsider the censor.
We're going to reconsider.
Well, that we need a motion to
And then we're going to go through, the procedure that we just talked about. And I'm going to follow the censor. So I will have a letter with everything on it to Dr. Pandya, and he will have time to rebuttal, and we'll have witnesses. There's one witness. And we'll conduct this in open session at the October board meeting.
But you need a motion to approve reconsideration though.
Mhm. So if we approve reconsideration, that's what happened. So it's up to you all to approve, or if you disapprove, we're finished.
Are you making the motion yourself?
No, I'm not making a motion. So it's up to the board. It's their thinking. You want to drop it or you want to continue with it?
So I move to reconsider the censor resolution.
You move to what now?
Yeah, it's, I think.
But we have to have a motion made, then we'll have a second.
Himself. Too.
Then we'll vote on it.
It's no context.
So we have a motion by Dr. Pandya. What was the motion?
For reconsideration.
Motion for reconsideration. For
You
the
vote
censor.
for reconsideration?
No, it'd be a motion and then you'd need a second before there'd be a vote.
Yeah, I just still don't know what the motion is. You want to reconsider your censor?
Correct.
Okay, do I have a second? I'll second it. Now, we'll go down to Dr. Bell, yes or no?
Yes, reconsider.
Dr. Segretti?
No.
No?
No.
I vote yes.
I'll reconsider.
Yes. Dr. Pandya?
Yes.
Okay.
I got a question.
4 yeses and 1 no.
I have a question.
Yes.
So if we reconsider the censure, does that open up from, like, because we get a sworn testimony and it comes out, it sounds even worse than what we originally heard or anything? Is there additional stuff that could happen, or is this just censure or that's it?
It's however you feel. Once we hear we're going to hear very similar information. So
It'll be sworn testimony,
in the
no?
2 months that
Well, it'd be the same.
we've
Same
waited.
exactly what we heard before.
Been
Mr.
waiting.
Chairman, can I make another motion for something else?
Well, this motion passed.
Yes, but there's something
So
else I need to.
the motion passed. So now you can bring up something else, sure.
Yeah, same related matter. Yeah, this passed, I'm fine with it. The restriction, there's some censor, but there were some restrictions we put on him meeting the CEO one-on-one. I would like to make a motion that we keep those restrictions pending the full.
Oh, everything stays in place
Everything stays.
until
Yeah.
the next meeting. It's just to reconsider the decision.
Right, so that'll be at the next meeting. Okay. Move on. CEO evaluation. I'd like to take this and have it at the end. We need to have a discussion in closed session first, I think, and we haven't covered that in closed session. So let's put that on hold. We have business items, the cath lab, CBR, and the US News and World Report. Up to discussion.
Oh, we got some data.
Great. Thank you guys for having me. This was kind of a impromptu to have me here today to discuss some quality. It's actually some exciting news, but I'm going to kind of lead into it. So just if you'll give me a minute. The powering of performance. So the cath lab uses the NCDR to report our data information, the registry. But the American College of Cardiology, that's what they use to guide us. They give us all of the quality and the areas that we need to improve. And when we follow their numbers, it shows us where we sit. Different ways of collecting this data is either a software vendor, which is a third-party company that we could pay to extract our information and plug it in, and Doug would be probably reporting something different. A data abstraction provider, they're a hired data collection. So other hospitals use people that they hire or bring them in. They extract the data from all of our information and then they plug it in. Also, again, another cost. We choose to do the web-based data collection. So I'm thanking Jill Bionis because one of our nurses takes our information and she plugs it all in to the NCDR for us. We don't have an outside company doing it. We don't have just a random person doing it for us. We're pretty intimate with our data, so we know what's going on. These are the requirements, kind of cut off there at the top, but there's 11 different ones at the beginning that we have to start answering. And as we answer each one of these, be it the diagnostic or a PCI procedure, the insurance, the patient's history, their risk factors, the cath lab visitation indications, and you go on and on and on, and that's about 11 of them. This list will continue as we keep answering these questions up to 165 quality indicators that we have to answer per patient. If we miss one, it doesn't go green. Green means that all of our data is entered correctly. We'll get a red light or a yellow light, and it'll tell us that we have to answer more questions. So up to 165 questions per patient. Our new software that we have just implemented this last week, I give props to the team. Windows 10 was upgraded. We had found out that our old system had an old Windows 7 on it, so it wasn't able to upgrade, so we did have to start with that. Then we did build the CCW to collect our information. The MATLAB was built. Meditech was integrated, which we already had parts of Meditech integrated, which Meditech is our paperless system. MATLAB or cath lab was part paper and part paperless, and now we're going to be almost 100% paperless. The staff is in the process of being trained. We have a new report that does print out from MATLAB, so no longer will we have to use an old-fashioned audit to collect the information we need to put into the system. It'll actually give us all the information, and Jill uses that information to plug into NCDR. I want to thank Ron at this point for setting us up to be the best unit with the best quality. If it wasn't for Ron, I wouldn't be standing here today. So for the quality that he wants to push and strive for our department, I give props to him. I also want to thank the board for signing off on this project. This was a huge project, and I want to thank you for signing off the $300,000 that we spent to do this. Here's why I'm here today. US News and World Report came out. When they reported out, the American College of Cardiology has Sierra View District Hospital in there. This is the first time we've shown up in a US history, or I mean, a US News magazine. I don't have copies of the magazine, but I do have copies for everyone, because they sent it to me by PDF. This is huge news. There's about 2,000 hospitals that report to this same NCDR, and we're one of them. What's next?
What is ours?
We're towards,
Rating?
it doesn't give you by number.
Oh.
It just gives you by what you collect. So we collect NCDR, PCI information, so that's our symbol that we have. What's next? We're gonna partner with the American College of Cardiology to have an accredited cath lab. We are licensed by the California Public Health Department, but we want an accreditation from American College of Cardiology. So that's our next step. My last thank yous to the board for believing in us. Donna Hefner, what can I say? She comes down, she's our cheerleader. She has pushed us. She pushed to have this cath lab built. I wouldn't be standing here today if it wasn't for her pushing us. I can't thank you enough. Ron, thank you for pushing us. Our cardiologist, Dr. Bell, Dr. Reddy, Dr. Thiokran, Dr. Gupta, and of course, our nurses and our techs. They're the front lines. So I appreciate it. I thank you. I thank you for having me today. Yes.
There's one additional thank you, and that's to Tori. She has logged in probably over 300 hours on this project, on getting us new software, of which she also traveled out of state to Wisconsin to a training facility with Siemens. And so if anybody knows Tori, she's a family person. So she left her kids at home with her husband for a week. And she also missed her daughter's driving test. But I say that because that just tells you how dedicated she is to CRU and to our cardiac cath lab. So Tori, thank you.
Is marketing ever gonna be, this is something good for marketing with the paper, along with Jeff's award and the others. And do they normally stay here or they just not?
Yeah,
'Cause I think marketing, some person should be here to hear this stuff. But several meetings,
Sorry, they're viewing it, they're just not in here.
okay, but you're all sitting here too. So you've taken your time to sit here. I think marketing, because a lot's going on lately that we need to have in the paper, and that's very important. And they're a big part of it. So at least someone, I think, should be here to take notes and say, hey, we want to put this in paper. Because they've taken time, so sure, they may be over there, but we're not going to contaminate them or give them COVID. So it's just a thought. I've noticed that marketing is an important part of this. And it should be there.
Okay.
So anyway, thank you for that. Good job, everybody.
That is great.
Okay, next is the public records.
Yeah, this item is, we had one request in, advance. This was from Mr. Eckhoff. And his request was via email. He had asked for the policies as well as the variant testing chart that we showed at the last meeting. And he also asked for, the proposed code of ethics disclosure as well as the sensor policy. So that was that, and it was produced and completed. That's all I have for that. That's the only request we had.
Okay, thank you. Now, Dr. Hudson, are you going to give us a code
Yeah,
that's
just,
been destroyed?
You want to start, Donna? You want to start with the big picture?
Yeah, so,
The data. How's that?
that'd be great. Okay, and then Tracy will provide some additional data afterwards. So since August 9th, we've been in an internal triage code 1 based on our policies and procedures. It's truly, we just lifted it as of September 23rd at 16:30. It was the first time that we actually had a sustained amount of time where we were holding less than 5 patients in our ED. We saw upwards of 59 patients the weekend before Labor Day, and we have actually been under siege for over that time period. So on Labor Day weekend, Jeff, myself, and Brandy, as well as a number of leadership, were here trying to determine, it became a real staffing crisis for us. This surge, unlike the other surge, was a little bit different. We've had we had over 100 employees out on a leave of absence of our 1,016 employees. Coupled with taking care of their sick children, it really became quite a strained system. Leaders were working nights. Kevin Dooms worked nights and trading off with Shay, as well as Brandy and Hannah, and pulling various long hours. Jeff and I were at bedsides at various times, and it just became almost to the point where it was very unsafe. And as a result, I made a call, and you saw that probably in the media, we actually had 9 paramedics and 8 EMTs that came during a time period to help us with at night. They arrived at 7 at night. They left around midnight to about 7 o'clock in the morning. And that resulted in us receiving about 19 additional hands. They resulted in LVNs, CNAs, RNs, and we onboarded them over the Labor Day weekend. Those individuals were here for about a week. Some of them were longer. Some of them we had them for 4 weeks, some of the RNs. Great help, but the actual additional help that came last Tuesday resulted in 22 RNs coming to help us. And that's where we really started to feel that we could get patients. And I think that really is what contributed to us coming out of Triage Code 1. So I've had conversations with Secretary Galley. I was on a call with Madera's CEO, as well as a number of other CEOs, CEO from the hospital that's up in Heavenly Valley, as well as this Dignity CEO in Sacramento. So we were in a very much hot spot surge area. Madera, as well as Kern, are also seeing numbers is the same as ours. I can happy to tell you, we did peak by the county numbers. We did peak on Labor Day, but our trend has been a slow decline. It's not been a drastic, a decline where the numbers have just dropped off suddenly. But over time, we're sustaining our staffing models, and it's actually helping the ED with throughput. So I just wanted to share with you, there's some new developments things that we did that were different than the first time. We went to an extended 48-hour club, which Adventists caught on to our 48-hour club and kind of duplicated it. So we had to get real creative in having an extended 48-hour club, which is now we have 2 48-hour clubs. And so the extended allowed us to pick up some RNs to pick up additional hours. Unlike the previous 48-hour club. We did have to go into double time in a triage code status, which we had never done before. And we went to leadership briefings. I've had about 5 consecutive weeks of leadership briefings, which is just 30 minutes to say what's working well, what's not working well with our leaders. Dr. Searles has come to a couple of them and been there to support us with that as well. And really kind of listen to what the leaders are saying are the challenges. So last week we had a highlighter award where a number of our leaders, we gave out highlighters just to as a token of appreciation to say what went well from our leadership, and many of the leaders spoke up. So it was really a pivotal change for us in the last 30 days, but it has been a tough 30 days. I'm happy to say that the vaccine clinic is now going to be offering booster shots and flu shots as of this Thursday. So that'll be good for the Pfizer booster. So we have some new developments to this as well.
Do you have Moderna booster too, or only Pfizer?
Not been approved yet.
Not just the Pfizer right now. So those are a few things I wanted to share with you, but I am happy that we are out of the triage code 1. We do have these 22 RNs here for 4 weeks. So we are upon us in winter months coming. So we're hoping to give our staff some of the break that they need to get them rested to withstand some of the winter surge. So that's kind of where we're at right now, outside of those people that are on leave. So I'll turn it over to Jeff to give you some numbers.
I have a question.
Yes.
Out of 132 approved beds, how many you're filling because of the staffing issue?
Yeah, so staff beds is something we have the capability of going up to 34 in our COVID unit. At one time, we were staffed for 34, but it varies. we have 10 ICU beds and we've been caring for 12 ICU patients. So we've been going outside of 100% of our occupancy. So it's really, you can't say like in a 30-day period, how many beds, we had 167 beds, we had 167 staff. It varies.
So it's mainly a staffing issue.
It is a big staffing issue. Yes.
It's also the collision of the surge. So as we saw in September, end of August, we saw that volume go up to over 100% capacity of the hospital, some days at 105%. We're staffed normally for about 77 patients a day, and that is way beyond that capability. So we've now seen that trend going down. Today, this afternoon at 4 o'clock, we were sitting at 77% occupancy. So with those additional nurses that Donna talked about and that volume, we're able to handle that pretty good. So you'll see, Doctor, that we're going to go back to letting some surgeries happen next week. So Dr. Bardwaj and Kristen are working that out tomorrow. There'll be a message coming out, so we'll preview to that. But that's been our major problem, is that we're still operating two hospitals, a clean hospital, a dirty hospital. You got to divide staff, divide beds, divide units, and that's problematic. But good news is we seem to be seeing some decline, to Donna's point, that we've hit the peak. But of course, that keeps going up even when you hit that peak for healthcare, and then it starts to do a trajectory downwards. This last weekend, 367 new cases in Tulare County, over 650 in Fresno. So still seeing a number of cases that are alarming. 6 deaths over the weekend here in Tulare County, 12 in Fresno. So we're about half of what is happening in Fresno is happening right here in Tulare. So sort of as a marker for you. Today, and every day now for the last several days, we have an average of 30 to 35 COVID patients in the hospital, anywhere from 5 to 10 who are suspect patients who are being held in the COVID area until we can rule them out because they have symptoms of COVID, but we've got to do the PCR test, which has to be sent to public health, which I've been telling you that for a long time. But we are going to bring PCR tests in-house where we do have the machine now. So when we have that capability, that will really speed the process up of working with those suspect patients. Instead of waiting 48 to 72 hours to get those results back, we'll get them back within several hours and be able to keep the patients moving in the right direction. So that will help immensely.
Will you be able to take the outpatient referrals for PCR or not really?
Say one more time, Doctor.
Will you be able to take referrals for outpatient PCR testing or not?
No, we'll only be doing inpatients.
Only the inpatient?
Yes, they'll still go through public health and other places.
That's going to be a supply matter.
Yeah, I don't think we will have the supplies to be able to do that. We're on allocation. I don't know that he'll be able to do that. Maybe in due time. But right now, everyone is fighting for the test, whether it's the PCR or the antigen test. With all the school testing and everything that's taking place, it is very hard to get testing. I'll just say that going out of the country. Dr. Bell also had someone go out of the country. It's hard to get tested in America and get the heck on a plane and get out of here if you want to.
I think it was very hard move for your equipment. You know when it'll be fixed? Running?
The BD analyzer. Yep. When
Are
it's
they
gonna
gonna
be
put a
fixed.
rush on that to get it working?
Yeah. I haven't got an update this week.
Yeah.
Do what?
I haven't got an update this week. My update was last week, so I don't.
So we have it in the lab, but it's not working?
That's what he told me.
Yeah, we have a new machine that is inoperable, is what
They're gonna bring us one.
So they've got to get it serviced.
Bring us a new machine pretty quick.
I don't know that.
You better tell them we'll buy it someplace else.
Yeah.
But we need to buy the
If they don't
specific
bring it
vendor so
quick,
that we can,
together another,
we need to have a specific
Supplier.
vendor, so we have supply.
Bring you
That's the
one that
really
works.
thing, so. But I'm sure Gary is working on that with due diligence because it is so important to us. So other than that, that's sort of where we stand in the market. I can tell you at Kauai right now, they see a lot more patients. They have 108 or so COVID positive patients, average about 17 in their ICU. We're averaging 5 to 7, 8 patients. And that sort of numbers going down the ICU. So that's come down from when Donna told you we were outside. We've been in the boundary of the ICU now since Thursday afternoon, Friday. So that's been good.
Are we gonna do boosters over here?
At the Pearson and
Our
Morton,
vaccine clinic.
yes,
We'll start doing the booster on Thursday.
yes, starting Thursday.
So if you meet the criteria, you can go and get the booster if you're a Pfizer person.
You have to show your card.
We are doing Regeneron.
We do Regeneron and we're doing about 10 to 15 cases a week. We are on allocation. There's so much Regeneron being used across the United States. We're all on allocation now from the state, so you can't order it. You have to get it on allocation. So if it runs out in a particular week, we're done. I think you'd have to go somewhere and find another dose.
I didn't hear you, I'm sorry, how many are you doing a week?
10 to 15.
How do you get one of those? You got to just
For Regeneron, you have to have an order from the physician, meet the criteria within the 10 days and all the, all the
High
things. you have to meet.
risk, right?
And then
You can also do
direct
BAM. We also have a lot of doses of BAM, so there's a choice of
admit,
doing either one,
outpatient.
but we can do
You're
those.
doing this as an outpatient infusion? or
Yep.
Yeah.
In the,
Doing them on the third floor.
third floor outpatient?
I think the definition is they have to be pretty well, right? You don't want to catch them, I think it's too late.
Yes, can be on, oxygen and all those sorts of
Yeah,
things.
early.
There's very specific.
And we still use the rest of it.
Well,
Remdesivir.
Yes,
You can still
When
use
it's
this,
appropriate.
yeah, it prevents
There's
hospitals.
some good data coming out.
yes, we use remdesivir.
So in
On that.
addition to the monoclonal antibodies, Melissa's has been heading up the employee testing. So I wanted to kind of transition into her to give an update on the testing component that she's been running our testing clinic for our employees. So
I had a question on staffing. Is that kind of what you're going to deal with as well, like the mandate on 30th?
right, and Tracy's gonna come back. Yeah,
I'll wait till we're
it's a
done.
team sport around here.
I just want to make one comment, open session for the public. I know Donna kind of underplayed, but I was here Labor Day weekend and I saw Donna and Jeff with the boots on the ground.
Mhm.
They were here pretty much, they were on the ground helping everywhere. So, it's really nice to have somebody who can do that, a BCU. I was telling Gary about this and he said, unfortunately, I couldn't do what Donna does. So just wanted to compliment and for a great work you've done. That's a perfect leadership where commander is in charge. So, leading the troops.
Thank you.
So I just wanted to, comment that.
Very good, good job. I
Yeah.
think everybody's doing
Yeah.
an outstanding job on this COVID. Could I ask Ron, could you check with the lab and see what they're doing, if they're going to give us a new one? On the PCR and as quick as they can? Because that's very important to have that here. And they shouldn't send us a bad one, their quality assurance is bad.
Okay.
But see if we can get it real quick, would be nice, if they could do that.
I'm sure you'll have an update by the end of the night. So Melissa, can you get an update on how the testing's going?
And just, we want to thank Jeff and Donna very much. Great job.
Thank you.
Thank you, guys.
Hopefully we don't have to face it again, it's the same crisis.
I'm hoping not.
Christmas time, I'm worried.
I'll be here.
Justin or Andy, he help out?
Ron?
Yeah, Ron, yeah, Ron.
Yeah, yeah. Uh-huh.
So all the RNs were jumping in and.
Well, yeah, he was helping me on the lab side, so yes.
All right, so our staff members who have either filed for and been approved for an exemption or have not yet completed their vaccine series, they are testing and they are required to test twice a week unless they work one or less shift per week. So we have a testing site that's kind of set up down in one of our conference rooms 3 days a week, and we're gonna be extending those hours, looking like probably next week to catch more of our staff members at convenient times for them. So it's a self-administered test of the NARES. They come in, they sign up, they do their test, they pop it in the bag, and we send it off every day to Valencia, to the CDPH Valencia lab clinic. They then turn around the results. Our staff register online through the portal. They have an account, so every time that they come in, the test is assigned to them. They then get the results usually within 24 hours. And we did have a couple days where there was a delay because they were doing quality testing actually on their specimens. So it delayed that probably an additional 12 to 24 hours than normal, but usually the results come back the next day. So they get a text message or an email, depending on how they signed up, with their result, and then employee health also has a record of that. So any positive test results are then being followed up on by employee health and HR. So that's been our process going forward, and we'll continue to maintain that throughout the time that we need to for these employees that fall into either the exemption or have not yet completed their vaccination.
I have a question for you. See, somebody come back positive and then they go in quarantine for 30 days. Then they get tested again and they come back positive again.
They don't get tested again. They will not get tested. If you're positive, you do not get tested for a minimum of 90 days.
Or 90
They'll
days,
just continue.
not
If you
14
continue to
days.
test positive, you just never come back.
So they don't work for 90 days?
No, they come back. It's an absence of symptoms that the quarantine goes by.
But what if they are still positive?
I'm sorry.
What if they are still positive and they're spreading the virus?
The virus shedding is based on symptomology and the resolution of that. So once those symptoms start to resolve, that then starts their window of when they can come back, because they have figured out the shedding cycle, and it's based on the resolution of those symptoms. If they're still not well enough to work, they would still maintain being out because they are not well enough to work. But then we continue to work through the quarantine process.
So you're talking about things like coughing and chest pain and
Right.
shortness of breath. I see,
Yeah.
clinical. That's a clinical decision.
Correct.
I had a question. What's the cost on that testing? The cost on that testing? Zero. Okay, that's the best cost.
So we do have a little bit of fee with transport, but we worked out, working with the county, they gave us, Tim Lutz gave us a lead, and we've actually brought the drop box that was out at PDC is now anchored on our campus. So our drop box is right here, and then they pick it up every day and take it down. So we have a little bit of that cost for transport.
And I don't even know if that's the case, because they just set up the transport, and so we're just gonna see.
So we're not absorbing the cost like we were thinking we're gonna have to absorb the cost on.
No, the worst case scenario that we had was a courier, but that, even at that, was just over $200 each day to transport large, all the samples down. And if we do the FedEx, if we purge that out, it's probably closer to about $70. At this point, the lab is actually just, because we've sponsored the site here for the Dropbox. They just set up a daily pickup at 5 o'clock, Monday through Friday, whatever's in there. So the community would also, there's a survey they go on, if they're interested, they do the survey, that there's a contract with them. And then it gives them a lockbox code, and then they have access to that. So they can also come and dump, and then the courier picks it up and takes it down.
What kind of numbers are we getting on the employees' positivity, and are we getting quite a few or?
No, not really. We did the first go through, right? Because the likelihood or the odds that we have people who are not testing because they were not symptomatic, that would have a positive, because they were positive within 90 days and didn't know it, right? They didn't have symptoms, or the symptoms didn't rise to the level that they thought, oh, I should get checked out. So we did have a couple that came through, but the interesting thing is we've had a couple, we've kind of toyed with this, that were false positives. So they came back as a positive or presumptive positive. We sent it for PCR, and about 50% of those are negative, which is good, right?
Yeah.
So we do have a double checks and balances, and there's some science behind that, because they do batching when it comes to the testing. So the whole batch goes in, and if the whole batch comes back negative, everybody's good. If there's a batch where there's a positive, then they have to go through and identify it, but the sensitivity is less than that of a PCR, right? So the PCR, they replicate about 20 times, whereas this, they don't. So there is some margin for error, but knowing that anytime we get one that's strict, rather than going through the whole process, we go ahead and send for a PCR to get a confirmation on that.
And my point was, is it something that's really saving? I mean, is it an exercise, or is it something, is nonsensical testing, or is it go by clinical? I mean, you do test everybody, it means nothing. Clinical is still important. Patient has symptoms, usually more likely that they have positive means something, right? You're testing routinely everybody. Bayes theorem, there's a Bayes theorem. Pre-test likelihood of disease is low. So a false positive rate will be much higher than otherwise. So it's nonsensical. It's like a regulatory testing. And I'm just, my comment, they do it at the state too. Every patient, every person is tested twice, every week. It's nonsensical. There's no science behind it. That's what that's what something is.
What percentage of people are vaccinated in the hospital, the nurses and the staff?
That's a good
So,
question.
yes.
That's fair for them, right?
Great question.
It's all to Tracy now.
For it here.
Use a lot of questions.
So we have 79% of our staff are vaccinated. 15% have an exemption, either religious or medical. Those are the only two exemptions allowed by mandate. And we have 5% that are still unknown.
No, they're gonna be tested every day, twice a week,
Yes, forever.
The exemption, yes.
or are they gonna not work like nurses are in the paper?
No, they got the exemption.
Some
That would
nurses
clear.
are gonna be, take shots and they're gonna quit. Do we have any of that?
No, that would clear them. The exemption clears, I'm
50%
sorry.
have signed the exemption. So the people who have signed the exemption and then it's been approved, they will test 2 times a week until we hear otherwise.
Right.
So we,
The 5% that are still unknown, they have until the 30th. At the time of.
September 30th or?
Yeah.
Yes.
Yeah, we're coming
These
close.
people that are exempted, for whatever reason, they're only exempted from COVID or from all the vaccines that are available for them?
No, this is specific.
That's a good question.
What's the reason for that exemption?
There's 2 to the mandate. So the state
I mean,
mandate,
they're not exempt from the flu vaccine, but they're exempt from the COVID vaccine?
well, they may have a religious exemption for flu. That's a whole different process. So when flu season comes around, if they don't get the flu shot, then they have to wear a mask during the flu season.
Which
So,
we are
or
anyway.
sign a declaration.
Yeah, that was that.
Right, but the COVID mandate is the state mandate that's not implemented by us, so it's very specific. And there's only 2 exemptions that are allowed. One is a religious exemption, the other one is a medical exemption. And that's the only thing that we can accept. The medical exemption does have to be signed by a physician for medical condition, and that's also more of an interactive process. So that exemption is a little bit more invasive in the terms of the physician controls whether this is a temporary exemption and that they could later be eligible to receive the vaccine, or if it would be permanent, that they would need to be exempt and require testing.
so the good news is of our 1,016 employees, we're down to 30 active employees today to determine a status by September 30th.
So we're
So
not
that's
really
a-
impacted that much.
Well, we have seen a lot of employees leave to go travel, but not leave because of the vaccine. Now, we still got 30.
Small hospitals. I mean, people leave from here to go work in Delano, from Delano, they go to work in Bakersfield because they make more money that way.
Yeah.
Yeah, travel money is higher, so.
Right.
Yes.
Economics.
But they can't move. They have to get it. They can't go to another medical facility, right? If they leave here. No, they can't after the 30th though. They won't be able to work anywhere unless
Right, if they don't
they
get
got
vaccinated.
exemption or
Yeah.
vaccination.
After the 30th, they gotta be
But the
vaccinated.
reason people are leaving is for higher money.
So are you seeing, is there a cluster? I mean, you probably can't tell me what kind of staff members are, but is this nursing staff, maintenance staff? What do we do? Because you got 30 people, right? That you're,
It's a combination.
it's a combination.
There are-
So it's not a cluster area, like we're not like the OB department's not gone as of, okay, good.
It is spread around the organization in all different areas.
So it'll be a minimal hit on that day if they have to be, okay.
And there's still opportunity, so they could, on the 30th, they can go get the
Johnson Johnson, right?
vaccine and be still,
So
meet the requirement.
the travel companies have same restrictions, obviously, right?
They do,
Everything.
yes.
From the medical staff, the number of active physicians that are, do you know there's a percentage?
I don't know that.
I do. Yeah,
100%.
so it's close. There's only 4 providers that have asked for the exemption. So of your 120, everybody else is vaccinated.
So they have to wear a mask.
They have to get tested
They
every
have to
week.
get, those 4
So
that
they'd be
that have
tested.
an exemption have to be
Everybody has
tested.
to wear a mask, yeah,
Yes.
but they have to.
You're talking medical,
The medical providers,
have not taken it.
correct. Yeah, that's not bad. It's a high percentage of vaccinated. That speaks volumes. That's what I've been kind of using as a message. If our medical staff is, accepting of the vaccine, it speaks volumes, so.
So after the 30th, are we still gonna wear masks?
Yes.
Everybody.
We're in this for a while. Yes, we are.
Mask is part of the styling.
That's the surgeons, you have to wear mask all the time now?
It's part of the dress code. It's part of the dress code now, right?
Right.
That's right.
We're wearing these totally.
Yep.
And just for the final follow-up, behind the delta is the moo. So the moo, MU, is coming next.
That's the next one.
The next variant is in the United States.
Oh, really?
We're seeing it in California.
Where is that coming from? Who?
Oh,
South America. isn't it?
Colombia.
Colombia?
it's called move. It's a cow virus or something?
It's a letter.
Or the R1, Jeff, there was some R1, there was something like R1. R1.
The new variant, you mean?
Some of the variant called R1.
No, I think the variants are named after Greek letters.
Yeah, they're
right?
all the Greek letters. That's why you're seeing.
Mu and lambda.
Which is part of the Greek letters.
That's when I said R2D2 is coming next.
Yeah, R2D2, yes.
Oh, gosh. Hope he comes with his vaccine.
Okay, very good. Any more questions on COVID?
Well, just.
Next meeting will be October 26, 2021, in this room at 4:30. So I will adjourn the meeting at 6:15. And let's take about a 5-minute break, and we'll meet again for a closed session and then another open session.
And I think
Go ahead.
We're live on.
Yep, exactly.
Hey, we've just gone out of closed session, back into open session, and we will cover items C, D, E, F, and G that we didn't cover in the first open session because of running out of time. So the first item we will cover will be item C. And that dealt with the term limit. So it's something the board, whatever you think, you want to put it off for a while, table it, or what would we like to do with term limits?
Is there a motion to table it to the next meeting?
I'll motion to table it.
We have a
Basically,
motion to table. Do I have a second?
second,
Second. All in favor?
aye.
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 Also, is there any discussion allowed on the issue? Will you allow discussion on that?
Sure, you want discussion on term limit?
Well, I think we're all going through a very, hospital is, the district is going through a very difficult financial time, and $250,000-$500,000 is a lot of money. So I think we have to see if it is really worthwhile doing that or not. It's not like the water board, whether you get water or not, that's a different thing. But we are dealing with very complicated issues. And it does require track record and learning. I mean, look at Dr. Bell, he has done such a good job. But he's been on the board for a long time because he has a track record of understanding what's going on.
Mhm.
And I think that's an important thing to bring to the table. That is seasoned.
Well, we're going to table it to next meeting, so let's hold this discussion to next meeting, and we'll come prepared to bring some good thoughts up. So that's a good idea about Dr. Bell. So we've had a motion to table, seconded, and voted. So we'll hold our discussion for the next meeting. The next item was to give Mr. Dixon the okay to negotiate purchase of a property. So I'll either take a motion to approve or disapprove, giving Mr. Dixon the okay to negotiate with property, sale of property, purchasing of property. So a motion to either approve or disapprove.
Is that, may I make a comment, Mr. Chairman? Do we have other avenues of investments in the clinical items and other things that can produce probably little more return on investment than 5-6%?
Let's not get into the
Yeah.
details of the.
This is.
Yeah. You get an investment, the CFO gave you a full financial investment presentation at the last month's meeting. And they are leveraging according to the policy and the limits that we're able to invest, we are very limited on what we can invest in. And that restriction comes down from the state. That's not something that's imposed, that we impose upon ourselves. There's certain caveats. And so that the board has been given quarterly updates on that.
So my point was about clinical service line. As for example, enhancement of the cardiac cath lab. If we can invest something in it that can ultimately down the stream increase in revenue.
Let's hold that because we're getting off the topic. We're considering giving Mr. Dixon the powers to negotiate the purchase of property for the hospital. It's not necessarily for an investment because our investments are stocks or mostly bonds. It's more for growth of the hospital. And we're running out of space for physicians, and it's cheaper to buy property that's already made and ready to move into than build on our own and have to purchase the land. So we have to make a decision if that's something we want to move forward with, to have spaces for more doctors or wait and look at something else. So that's what we're thinking about. So if you think we need to wait and see what else comes up, then so
Since
why
the
don't we take a
strategic-
motion we can go through several. So whatever motion somebody wants to make first, make it.
Yeah, I feel like strategically it's in a good location and probably could use, I think makes sense. So I make a motion to approve that, to proceed with the process.
You make a motion to,
approve the, that
okay,
Dixon to
do you have
proceed
a
with.
second to that?
I think it's close by, it's in good location and there, and if we are expecting more positions coming up.
Do you have a
Good idea
second?
to put-
Do you have a second to Dr. Segurati's motion, and then we'll discuss it?
Yeah, I'll second.
Okay, now, any discussion on it?
So, and as council, I'd just like to advise that generally the questions and discussion to protect your negotiating power would happen in closed session with the negotiator there. And so it always makes me nervous that when you have these discussions in open, how much you're eating away at your negotiating power. So with that, I mean, go ahead with discussion. It's all up to the board's wishes, but it's much better for in the future to have these discussions where they can be protected.
Outside discuss, negotiate the best price you can find.
So we have a motion and a second to approve.
I think that if it is to be used for new physicians, it would be a good thing to enter into negotiations.
Any further? Let's have a vote. All in favor?
Aye.
Aye. All negative? No negative, so it's approved. The next two will go together. I want to read.
No, they're two very separate things.
Yes, the next one is, we're gonna bring back to the board next month. Item E was directors and officers insurance
Yeah.
Oh,
coverage.
that's right.
Yeah, that was.
We'll bring,
The errors and omissions.
Yeah.
yes, we'll bring a presentation back to the board
Yeah.
next month.
Okay.
So next board meeting,
Right, so this will be just for,
that would be one for Alex to add to the next board meeting.
Yeah, I have it on the notes, so that we'll make sure it's on the agenda and for today, I think it's
Gotcha.
information only.
Next item, F.
next,
Will be to,
Redistricting.
Already,
it's
For redis-
demographer, it's the demographer.
For the
oh, I got you, I got
Yeah.
you. You're not right.
Yes.
information only.
That's
So on this one,
description of the board.
Oh, discuss, oh, you had a vote on that. Okay.
yeah, on this one, it'd be whether or not the board,
Discussion. Do we want to continue or
We would
make
like,
a motion to wait till 2024?
it would be to find that there's insufficient time to complete the process prior to the 2022 election, and therefore
So I'll
to
entertain a motion then
Yeah, I make a motion.
So move.
seconded and
Second.
a motion's made. All in favor?
Aye.
Okay, so we're gonna 2024.
due to insufficient time.
Yeah, due to insufficient
Time.
Yeah.
Right. Now we will get to the right point.
G.
I'd like to read part of this after's contract. It says, the CEO will receive an automatic 2% merit increase per the contract. At the end of each year of this agreement, the board shall do a performance review and salary review of the employee's performance at or by the April board meeting. So we're a little behind times. We'll blame it on COVID.
I think at one time.
So Ms. Hepner's current rate is 400,795.20. And with an automatic 2% increase, it'll be up to 408,811.10. So when you started to say something about that.
I'm sorry, we had, one time we had decided to wait until the fiscal year is over and then do this process. I think one time because that reflects the previous year's activity. Anyway, that was just a detail. You said about April and we were late, that's why.
Yeah, that's why the contract's written.
Well, I'm not sure, I've not read the contract that well, but I think it's a moot point.
Anybody else?
So what do you, that means we're not.
So we
right
can,
timing, or we are-
right now,
No, we are behind, actually, we are
I think
already,
we're behind.
it's not next April, it's,
It's, yeah, it was. this
get over
year.
to you.
Right, yeah, the performance review
I know.
period is in April,
Yeah.
yes, but
So that's carried before the physical year, right?
yes, it is, according to the way the contract's written, yes.
Right.
Mhm.
So I,
We are behind now, yeah.
so we're behind.
Yeah, and I was thinking it's next April, then not true.
Yeah, but now now we'll be caught up. We've got it done today.
So I think you have done a great job. You put us
Now-
now US News, best hospital listed there, so I don't know how much more it came in. And then gone through the COVID, put in so much effort in there, you've done wonderful job. You deserve every penny of it, the raise, and maybe even more.
I concur with Dr. Bell. I think a couple of comments. I think you showed a good leadership. And I find the culture improving. People like to work under you. And I think there is some of that you see more and more. I think that's what the leaders do. Leaders elevate the performance of all of your people work for you. And I've seen that. And financial wise, I think every hospital is suffering in the country. I think we suffered too, but we probably suffered less than other people. And I see good signs going forward last couple of months. So I learned a lot of positive things here. And I think you're showing a good leadership. You deserve every 2% and more. I think we should look at it. Now, a question on that is, I thought the last few years, they were frozen too, from what so this was, you did not receive a raise last year, right?
Yeah, it went for when?
She deferred her.
I deferred it.
You deferred.
She
So
deferred.
so that itself is commendable. And I feel strongly we should honor that and add that to at least last year's to this year, and then go forward with
I like that, Mr.
appreciation.
President.
That's my.
Can we make this retroactive back to April?
I don't think we agendized the pay change in pay.
That's what we've done in the other years. It goes back to the contract date.
So
It's May 5th.
So I think as far as going back to May 5th of this year, right, it's just compliance with the contract, and so it was owed.
Okay,
But if you're gonna add back in the prior year,
no.
That would have to
Going
be
back to
agendized.
May.
I would say raise to go from 2 to probably 4% or something like that. That's my thought is that.
I think
Or at
that's
least
good.
match it up with the rest of the employees, just they are getting.
Yeah, I think you should
2.8%,
not
right?
get less than other employees and.
Yeah.
Well, I'll entertain a motion. I'll entertain a motion with 4% and retroactive.
no, I don't think you can do the 4% at this meeting. You'd have to agendize it as, because it's money that wasn't contractually obligated, because you already deferred that salary. So if you're
We
gonna
just
give,
carried the 2%.
if you're gonna give more than that, well, you can put it on the agenda next meeting. I don't want to stop that.
But that cannot be.
So I'm gonna move a little.
That's it, you're not gonna get your next check.
Next meeting?
If you wanted the 2% that was deferred to be on the agenda for next meeting, that would be fine. But for today, I mean, the contract's the contract, as she's saying, it's mainly just the board's pro forma of following through with what they were obligated to do.
So we need to table it to next meeting?
Not the 2% to May 5th, 2021, but the 2% from May 5th of 2020 to
To now.
2021.
Okay, we'll make a motion for that. We have a second. He just made the motion. We have a second.
What's the motion?
Again, can we?
To 2% retroactive to May. And next meeting, we can have
Discuss
agenda a raise,
for the missed.
another 2%.
Yeah.
So I think the motion, to be clear, the motion would be to approve the employee public performance evaluation.
Right.
And to execute the board's obligations under the employment contract.
Okay.
So I make a motion as it was
As
just.
the attorney eloquently presented.
Yes.
Yeah, you did a very
Do we have a
nice job.
second?
Thank you.
Second.
All in favor?
I-
Aye.
Thank you.
But it would be hard to increase that beyond what all other employees are getting, because it will have a negative connotation on their minds.
But that's why it needs to be on the agenda for next meeting. We got to notice it. You got to make sure that's, the public knows that we're going to talk about it.
Talk about it.
So I think that's a good thing to have on the next agenda.
Item H was information only, and item I was information only.
Right.
All right. Thank you
I'll
very
adjourn
much.
the meeting at 7:50.
If you have a hungry family members, you can take an extra sandwich. Or just if you miss lunch.
Tomorrow.
7:54. 7:54.
Thank you very much.
I'm a Subway fan, so.